So it's a pleasure to welcome you to this live event today from the University of Tübingen. Today we will have a very, very exciting event, a very exciting topic from internal medicine, and we will speak about the immunotherapy of cancer. So this is something new for us, to be honest. And of course, it is important to introduce the experts. And first of all, it's a pleasure to introduce Professor Juliane Walz. Professor Walz is the medical director of the CCU Translational Immunology. Herzlich willkommen, vielen Dank.
Thank you very much.
And then it is a pleasure to welcome Professor Ulrich Lauer. He's the Deputy Medical Director of the Clinic of Medical Oncology and Pneumology. Vielen, vielen Dank fürs Kommen.
Grüß Gott.
And of course, I'm here with my colleague as moderator, and this is the medical student Rika Buchenau.
It's a pleasure. And I'd like to invite everybody who's here and everybody who's watching. All of you have the chance to get rid of questions, so if ever you have a question you'd like to ask, please do. We have Emmanuel, who has a microphone at hand, and you can just raise your hand and say, I have a question, please give me the mic. And for everybody who's watching live, you have the option to either write in the chat or write us an email.
Well, it's necessary to emphasize that we have a summer school here at the University of Tübingen right now. And it is a summer school of the Civic Alliance. And the CIVIS Alliance is a very important international alliance for us, where we introduce students from different countries. And I asked Professor Lauer, because you are dealing with this summer school right now, what have you done so far?
Actually, we went out for dinner yesterday.
Most important.
And this is a fancy place in Tübingen. It's called Boxenstopp. And this is where racing cars are gathered together, Ferraris and other type of stuff. And so we had a guided tour first, and we had a dinner. And we had good talks and interactions, but this is only the fancy stuff. Yeah, actually, we already had 2 lectures this morning, and we are in depth in the topic of this CIVIS Summer School, which is immunotherapy of cancer.
Okay, how many nations are there together right now?
I would say multiple nations, and if I would count, I would say 8 to 9. What
Wonderful.
Do you think? Yeah, 8 to 9 nations. And actually, we had an introductory part yesterday. So each of 2 students interviewed each other for about 10 minutes and then presented the results of their partner. So, for example, hobbies, scientific interests, what the next steps in career are, and so on and so on.
Great, so students are very knowledgeable and highly motivated.
Definitely.
Definitely, great. So Rika, what are we doing today? So we have a very special plan, actually. Can you tell us?
We'll be looking into 2 patients' histories. We'll be looking at one patient who Professor Lauer will introduce, with a solid tumor, and then we'll be looking at a hematological disease, which Professor Walz will be introducing. And those 2 will sort of guide us through the hallmarks of cancer and sort of what cancer presents us with, the difficulties that we face when we deal with cancer.
So we actually would like to start with one slide. And this slide, of course, will be known by our students here. And it shows the hallmark of cancer and the different strategies cancer has. And perhaps we can show the first slide to everybody. And this is what we see. So obviously it's quite confusing. And what I have learned from Professor Lauer is that this is just, it should be even more items. There should be more items to clarify how complex a tumor is organized.
Yeah, so the problem is that tumors always await our therapies. And you see here some mechanisms tumors are using to evade our therapeutic approaches. And as soon as we are successful, the next problem is coming up. So what you see here is only the top of an iceberg, and hundreds of mechanisms of resistance are just below the waterline.
Mm-hmm. Can you tell us, perhaps Juliane, can you tell us something about the history of immunotherapy? I always have the feeling that this is a quite new field. When I did study, I never heard about immunotherapy, but it might be also my problem. But
So indeed, when we go back in history, immunotherapy was already discovered very, very early. There are really early reports before anyone knew anything about the immune system and the different immune cells. There were reports about contact to specific viral disease that lead to reduction of tumors, without knowing that the immune system exists, but that was the first description of immune reaction against cancer induced by a virus-specific immune response. However, it took multiple years and hundreds of years until we now, or immunotherapy has now really entered the standard treatment of cancer, which is really a success of the last 10 years, that we now have in nearly all malignant disease immunotherapies of different kinds that are used during standard treatment procedures.
Mm-hmm, mm-hmm. So actually, we were with you in the clinic, and we had the chance to follow you during discussion about some realistic cases. And we would like to show you the first movie. And
so I would like to introduce the very first patient. This is a female patient, age 57 years, and the initial course was onset of symptoms in December of 2021. And at the beginning, there was a dry cough in this patient. Workup was without any findings. And initially, only a symptomatic therapy had been initiated. Later on, in January of this year, there had been an additional dyspnea, especially on exertion. And this was the reason that an X-ray of the thorax had been manufactured. And this led to the initial finding of a right-sided pleural effusion with complete atelectasis of the right lung. And also tumor manifestations in the right lung became first time visible. In addition, there was a computed tomography of the chest at an external hospital, which now exhibited large tumor manifestations of the lung on the right-handed side, with already displacement of the mediastinum to the opposite side, compression of the carina, etc., etc. Actually, due to a pleural infusion, there was an intermittent placement in the beginning of a right-sided pleural drain, a relief cumulatively of 4 liters of malignant pleural effusion with a hemorrhagic aspect. And then on, there was an implantation of a Pleurex catheter on the right-hand side. And later on, at the external hospital, first tumor conference led to the discussion how to proceed with this patient. And the colleagues over there decided to initiate an emergency chemotherapy at this time based on an initial histology showing a small cell, spindle cell, non-keratinizing pleural epithelial carcinoma. And the colleagues over there decided to start a chemotherapy with carboplatin and paclitaxel. Actually, the histology was renewed at a reference place, and for the first time then it was diagnosed that a so-called NUT carcinoma exhibiting a so-called BRD3 NUT-M1 fusion was becoming visible, and this was the reason that this patient was transferred to our hospital, University Hospital of Tübingen, because we are a highly specialized center for NUT carcinomas. And actually we have taken over the patient and started with the workup over here, including symptoms, including lab diagnostic and renewing the imaging. And I think at this stage we should have a look on the images which have been undertaken at the external site as well as at our site.
So this is the initial chest CT, contrast enhanced chest CT showing a large mass in the lung on the right side with invasion of the mediastinum and pleural lining, in particular over the upper lobe on the right side with shifting of the mediastinum to the other side. A tumor which was very well vascularized, as you can see here, with central so-called core necrosis, but most of it was very well vascularized. We performed a further chest CT at our institution 2 weeks later, showing within this interval a massive enlargement of this tumor with occlusion of the right bronchi and also the effusion, which was secondary to the tumor.
So at this stage, I have to say that NUT carcinomas are highly aggressive and they are very fastly growing, as depicted in this in our patient. And I think experts would recommend a so-called multimodal therapy, where we should take use of standard regimens as well as additional specific regimens which might be helpful for this patient. So what I would suggest is a chemotherapy which is often used in sarcomas, made up of vincristine, cyclophosphamide, doxorubicin and etoposide. And this, for example, could be used in addition to a radiation therapy of this bulky tumor mass on the right-sided lung, because the patient now is under continuous need of oxygen, and I think we need a quick relief of this tumor burden on the right-hand side of the lung. In addition, we could use a so-called HDAC inhibitor, which specifically could revert the epigenetic phenomenon being typical for this tumor. And we have lab data saying that so-called oncolytic viruses are able to destroy these specific NUT carcinoma cells at very low doses and in a very good manner. And this biotherapy could be added up with immune checkpoint inhibitor. In this case, I would like to suggest pembrolizumab. And I think this kind of a multimodal therapy would place a chance that this patient could be stabilized and in best case could have a relief of this continuous usage of oxygen. And on this way we could stabilize quality of life and hopefully prolong survival time.
That was a lot of information. And I was fazed by the clinical dimensions of that disease. I guess the radiology demonstrated it very well, and also what you described, how the patient felt, demonstrated it very well. But maybe we could go back to the basics and actually look at what a nut carcinoma actually is. Could you explain that to us?
Yeah, it's a quite peculiar type of tumor because everything starts with a gene translocation. And actually, this can happen in each and everybody. So there are babies, there are young children, adolescents, young adults, not that much older people who are affected by this initial gene translocation. And this gene translocation, we have a picture over there that leads to a fusion protein, which we call aberrant. So this is nothing physiology has foreseen. So the NUT gene, for example, is fused to a different partner, BRD4, and this ends up with a fusion protein. And this fusion protein can interact with the epigenetic machinery. That means that now when this fusion oncoprotein interacts with our chromatin, that chromatin sites are opening up, and that transcription of genes, for example, of oncogenes like MYC, is now ongoing. And this is a process accelerating, so more and more genes are activated, and this results in a very heavy kind of transformation, hard to combat, very aggressive, so that the mean survival time is within a couple of months. So to my personal knowledge, this is nearly the fastest growing and most aggressive tumor type, even in children, even in young adolescents.
It sounds like a catastrophe, and this is why I really understand that a multimodal therapy is necessary. And I heard one term during this short movie that you use HDAC therapeutical approaches. And what does it mean? It is connected to epigenetics. This is
right.
what you said. But
actually, so it interferes with this epigenetic mechanism. So this oncoprotein, which has been generated by this gene translocation initial, no longer can interact with the chromatin, so the transcription machinery is brought back to its initial state. So oncogenes like MYC are no longer that much transcribed as under this disease state.
Mm-hmm. May I ask one question? Is this a purely, primarily clinical diagnosis you do, or is it driven by the pathologists and the pathology of the tumor?
So the problem is that in the beginning you have quite simple symptoms, like our case patient. So you don't feel well, you lose energy, you have some pain maybe, some coughing, nothing dramatic. So normally you get antibiotics or something like that, and painkiller. And then if the symptoms are aggravating, somebody has the idea, okay, now we have to make an image, an X-ray. And then you get the first indication that the case of this deterioration of the patient is a tumor. And then the biopsy is taken as usual. And the biopsy normally shows it's a highly aggressive, undifferentiated tumor. But nobody at this stage has the idea it could be a so-called nut carcinoma, because it's very rare, very rare. And indeed, most cases are treated first time, and by surprise or not by surprise, the patients do not react properly to the chemotherapy which has been taken first place. And then everybody is questioning this diagnosis, the first diagnosis, And then the way is to the reference pathology. And the reference pathology has rare tumors in mind, and then they do a simple immunohistochemistry, really simple, and this is what we have seen with the brownish cells, and then the diagnosis is there.
Is that like a typical screening they do? So does every reference pathology do NUT screening?
In this
have an
case,
indication?
yes. This is part of the game, so to say, but not in the initial pathology because it's too rare.
Rare, yeah.
So they would have to take that 100,000 times to find one positive diagnosis. Yeah. If they don't have the context, the clinical context in mind, and the first glance of the pathology, which could lead to an earlier diagnosis.
So I never heard about nut cancer, and I would like to ask you, do you know this cancer type, this entity? Did you hear about this very rare specific tumor entity? It's necessary to speak about. We have to learn about.
So that's a null result.
Yeah. So why is it called midline tumor?
Yeah, because in the beginning, the first cases which have been described in the literature, so most of the tumor burden, like in our patient, are located in the mediastinum or the nasopharynx. And, but this is not a true case. Yeah? It can happen everywhere in the body.
Okay.
Is there anything that you would still like to ask? Anything that you didn't understand at this point? I know it's weird to talk in front of the camera, but still.
Perhaps we come to some questions later, because we will follow the case. So we have two cases, you said, Rika.
Yeah.
So that means the second case is not that rare.
I suppose maybe we'll take a look at it.
So I would like to present the second patient of our tumor board, which is a 52-year-old female patient with a chronic lymphocytic leukemia. The disease was diagnosed already in 2016 at her outpatient hematologist. She presented there with a cervical lymphadenopathy, and blood was taken showing an increase of white blood cells, as well as in the immune phenotyping, a typical picture of a chronic lymphocytic leukemia, positive for CD19, CD5 and CD23. The patient was in a very good health condition, so she had non-concomitant disease, and she had no problem from the chronic lymphocytic leukemia. So that it was decided to put her on a watch and wait scheme. This watch and wait went well for 4 years. She had regularly controls at her outpatient hematologist, but in 2020 she presented with a decrease of thrombocytes as well as an increase of her lymphadenopathy, which was at that time not only on the cervical part but also in the abdomen, seen by sonography, and her outpatient hematologist transferred her to the University Hospital Tübingen to decide about further therapy. What we did in the beginning was a CT scan that we could now present.
So we have from September 21 a contrast-enhanced whole body CT showing enlargement of lymph nodes in the axillary region, but also in the retroperitoneum and everywhere else, accompanying an enlargement of the spleen, and at the same time expected an increase in the attenuation of bone marrow as far as we can diagnose this with CT.
So the patient was then discussed in our hematological tumor board, and it was decided that she now needs therapy for her chronic lymphocytic leukemia. So the standard treatment for first-line treatment is treatment with the Bruton's tyrosine kinase inhibitor ibrutinib, which is oral intake medicine. And at that time, we had available a clinical study evaluating a personalized peptide vaccine in combination with the treatment with ibrutinib. So we presented a patient that option in increasing the efficacy of the CLL therapy by adding immunotherapy. And the patient agreed to go in that study. And before we started personalized peptide vaccine, we had to develop that vaccine personalized for the patient. So before the first intake of ibrutinib, we screened her for the study. We took blood that we used for the analysis of the personalized vaccine. And then the patient received over 6 months the ibrutinib treatment, and then came again to the hospital to have another checkup to see what the ibrutinib treatment achieved.
Okay, so we could see a completely different tumor entity. It's not a solid tumor, it's a hematologic tumor. And I have seen something which I think you would describe like immunophenotyping of a tumor, some very nice pictures, but for me it looks quite complex. Could you explain this to us? Why is immunophenotyping that important? And we have the slide again. Perhaps we can show the slide.
Yes, so in this case, we indeed have a hematological malignancy. Chronic lymphocytic leukemia is the most common leukemia in adults, so the complete difference from the solid tumor we have seen before. It's a very common leukemia, and it affects mainly elderly patients aged 60 and above. And for these hematological malignancies, we have the great option to directly analyze blood cells to get a diagnosis without needing a biopsy from a lymph node or the bone marrow. And this we did in the case of this patient because she had this leukemic CLL cells in her peripheral blood. And what you could see in this left picture is just a blood smear of the peripheral blood that we took. And you see the red cells are the erythrocytes. And you see here these large lymphoid cells, which are the CLL cells, which are mature B cells. So the B cells is one type of the adaptive immune system. They are usually responsible to produce antibodies, but in case of CLLs, this production of antibody is not working anymore, and the B cells have some uncontrolled proliferation in the bone marrow, in the peripheral blood, and in all other lymphoid organs. And what we then could further do to get a diagnosis is this immune phenotyping, where the cells are stained with specific antibodies. Oh, sorry. And in this case, we know that the phenotype of CLL is typically CD5 and CD19 positive. And this you could see here in this picture. So the red dots are cells that are stained for CD5 and CD19 and are positive for both surface markers, which is the approval for the diagnosis of CLL.
Okay, so this obviously is very typical for CLL. And the therapeutic possibilities changed. You told us at the very first beginning that immunotherapy took place in the clinic 10 years ago or something like that. That means, why does the traditional therapies not work sufficiently? Why is it necessary to go for immunotherapy?
So treatment of CLL has really emerged in recent years in case of immunotherapy, but also in case of development of small molecules, so very specific treatment of the CLL cells. So 10 years ago, the standard treatment was treatment with classical chemotherapy that just aimed to reduce the number of leukemic cells. Mm-hmm. And we now have a lot of small molecules that are directly targeting these CD5, CD19 positive B cells, specifically without targeting the other hematological cells, and especially not the stem cells. And we also have now antibodies that really specifically targeting these surface markers, which is a type of immunotherapy. And we now already have the combination of these small molecule targeted therapies and the antibody immunotherapy to reduce leukemic load. However, we still have CLL cells left, and the disease is not curable with the current treatments.
Okay.
And therefore, we are developing novel immunotherapeutic approaches to eliminate residual CLL cells to enable cure in the future.
So this would be a game changer.
Would be, yes.
Hopefully you succeed.
So if you had if you imagine you had a toolbox of immunotherapy, what would you put into that toolbox, and which parts would you like to be looking at today, for example?
Yeah,
I mean, it's a wide spectrum, so.
Yeah, it's a really large and ever-growing field. So nearly every day we have new high-ranked publication reporting about new immunotherapies developed for different cancer entities. So we have, I think, two large groups of immunotherapies, which are the unspecific immunotherapies and the specific ones. So this is just one type of how to divide these immunotherapies. And in the unspecific immunotherapies, we especially have the immune checkpoint inhibitors that were really the game changer in recent years in immunotherapies, because they take the break from the T-cell immune response, which are the main cells for anti-cancer immune responses. And we also have things like allogenic stem cell transplantation, where we really replace the whole immune system from a patient. And we have the specific immunotherapies, including antibodies, including peptide vaccines, including CAR T cells, that directly focus on specific cancer cells to eliminate them. And today we will focus on two highly, I think, promising immunotherapeutic approaches, which is the virotherapy and the peptide vaccines.
So how is it that before I even start doing some sort of therapy, how is it that I know, okay, for example, for a nut carcinoma, virotherapy might work, and for a CLL, peptide vaccine might work? How do I know that in advance?
So immunotherapeutic approaches are broad concerning their targets. They don't stick to a specific type of tumors. So it's simple to come to the conclusion, just use immunotherapy for each and every tumor. And just have a look whether it's working or not, and if it's not working, what the reasons are for that, and then to overcome these obstacles and to find ways that immunotherapy is running finally in each and every tumor.
So it's sort of like trial and error.
Yes, and just to learn and to improve, and finally to cure.
Mm-hmm. So diagnosis is, of course, a major task, and we hear about a term which is called personalized medicine. That means that we have to deal with a very specific type of tumor which is very individual. And could you explain on that, what is going on with this personalized individual medicine?
Yes, so I think the personalized medicine is now entering more and more clinical routine in diagnostics. We really could characterize an individual tumor in the complete detail, including the whole genomic information of a tumor. And we could, based on this, then really select personalized cancer treatments, which Professor Lauer already mentioned. So the aim would be to have the toolbox of immunotherapies, to characterize a specific individual tumor, and then to take out of these toolboxes the best immunotherapy approaches for these patients.
Yeah.
So more and more academic institutions and also smaller hospitals are setting up so-called molecular tumor boards. And in this, the recommendations are mainly based on genetic profiles. Protein profiles, RNA profiles, and so on and so on. And this profiling ends up in the search for specific drugs, small molecules mostly, monoclonal antibodies, this type of stuff. And this opened up really a new chance for each and every cancer patient to get his most effective treatment. Yeah. So I think that's the way for the future. But these small molecules, for example, they are mostly anti-proliferative. They don't interact with the immune system. So our perception today is we need something to stop the tumor growth initially, to reduce the tumor mass, and then to bring into an improved anti-tumoral immune response.
Okay.
So it's a two-sided concept. Bring down the tumor mass and then come into with the immunotherapy and consolidate.
And this brings us back to this hallmark circle. Am I right? You have a lot of tools you can use, and one of that is the immunological treatment. And perhaps you can explain the concept of viral therapy, because obviously this is your major powerful treatment you use.
Yeah, I'm happy to do this. What you see on the next slide is here in gray, depicted in gray, a nasty tumor cell. Highly proliferative, metastasizing, killing. And actually, nature has built up viruses which are able to infect these tumor cells, to replicate massively. So per tumor cell, there are many thousand new viruses made, progeny virus particles. And this is a process a tumor cell cannot endure. So every energy is put into production of new viral particles. And this leads to destruction of the tumor cell, the so-called oncolysis, you see over here. And the newly built viral particles are set free and then infect neighboring, hitherto uninfected tumor cells. And this is a kind of a wave working through a tumor tissue. And in the process of destruction of this infected tumor cells, many antigens are set free, not only viral antigens, but also tumoral antigens. And this is a very strong stimulus for immune cells, for dormant immune cells, for immunosuppressed immune cells. And then these immune cells are activated and will react to the tumor antigens, and they will find each and every tumor cells wherever in the body it is, in best cases, and then destroy the tumor cells. And even if the tumor cells are modifying, so they get new mutations, they are changing their phenotype, still the oncolytic virus will infect them, kill them, and set free these new antigens. So the immune system is continuously adjusted due to this oncolytic virus principle.
How does it work? If I may, I ask the question: how does it work that just the tumor cell is treated and it does not affect the other cells?
So actually, tumor cells don't like specific signaling pathways. So, if, for example, something a tumor cell is not in favor of is the so-called interferon signaling pathway, because if the interferon signaling pathway is intact, presentation of antigens is working nicely, activation of immune cells is working nicely, and so on and so on.
We have a slide for that too, maybe we can show
Yeah.
that.
And so tumor cells are selected for defects, especially in the interferon signaling pathway. And this is something which is good for oncolytic viruses because they are unhindered in their replication, whereas normal cells, you see normal cells over here, depicted in green. They are also infected by oncolytic viruses, but their replication is hindered due to an intact interfering signaling and other mechanisms. And as we do know, if a virus is infecting a normal cell, this triggers an antiviral immune response. And for example, this interferon, which is a cytokine, is getting out of the firstly infected normal cell, is going to neighboring cells, and these neighboring cells are in a defense state even before the next virus tries to infect them. So this infection in normal cells is called abortive. Infection takes place, but no replication. And this is the reason why patients who undergo a viral therapy, they have the feeling of transient fever, some headache, some pain for about 24 hours or something like that. But they don't have any organ failures or organ destruction or something like that, which is not atypical for chemotherapy, for example, for a systemic, very aggressive, unspecific therapy.
So would this actually work with someone who has like an immunodeficiency, who cannot, where this whole pathway does not work? For example, also like maybe CLL, I don't know. Would you think that virotherapy in CLL would work? Or maybe HIV would be a better example, I don't know.
So I think it really depends on the reaction of the immune system. So indeed, if you don't have any immune cells left in a really late stage CLL or HIV disease, it won't work. However, we have seen that immunotherapy could also work in immunosuppressed cancer patients that perhaps had previous chemotherapies and other treatments that suppress the immune system.
So maybe I have to comment. For example, a untreated HIV infection or an immunodeficiency syndrome would be a contraindication for treating with oncolytic viruses, because then the normal cells could not bring down this kind of infection. It would be ongoing and it would be destructive. So a minimum of intact immune system must or is a prerequisite for treating patients with oncolytic viruses.
No. So we have heard now that you have a lot of different tools, and I would like to ask if there are differences in the different universities, clinics, and so on, depending on different possibilities to work with the tools. We learned that there is this toolbox, and actually we organized something, hopefully it will work, because we asked our facility manager to show us his toolbox. And Mr. Steiner, he comes. So could you just show us one tool? So we have a lot of different lockers, and we have a lot of tools inside. So I think you can imagine that there are different possibilities. Do you think you have more tools than the facility manager? No. Okay, so this is something which is really very, very interesting for us now. To find out how many tools really exist in this case. And I would like to come to Professor Walz and to speak about the next set and the next possible tool. And this is the peptide vaccination. And perhaps you can explain us how this works.
Sure, sure. And in case of peptide vaccination, we really have the possibility to personalize this type of therapy and therefore expand the toolbox really vastly. So I already mentioned before the T cells as the central cells to provide to provide anti-cancer immune response. So these T cells are in the peripheral blood, and they usually detect tumor cells or also virus-infected cells via specific molecules on the cell surface of these cells. These molecules are so-called HLA or MHC molecules that present short peptides from inside of the cells. And these HLA molecules are presented on every human tissue and on every cell, and usually they tell the T cells that these cells are own cells that are not infected, they are not tumor cells, and the immune system should not attack them. In types of cancer and also infected cells, these HLA molecules present foreign peptides, tumor-specific peptides, that enable the T cells to detect these cells as foreign and to destroy them. And what could we do now to use these tumor-associated peptides for immunotherapy? We have the possibility to synthesize these peptides in the lab and to use them for therapeutic cancer vaccination. So we combine these peptides with so-called adjuvant drugs, so immune stimulation drugs, to attract the immune system. And we apply these peptides together with the adjuvants in the skin of patients where they are uptaken by antigen-presenting cells. These antigen-presenting cells then present these peptides to T cells, which in best case leads then to a proliferation of peptide-specific T cells that could then detect the specific tumor cell that presents the respective peptides and eliminate this tumor cell. That's for later.
So is this, I mean, you mentioned that this is also a process that takes place normally. Do we basically do this therapy because we want to have more T cells that are activated? Or is there a way for the tumor to also get away with its antigens?
Yeah. So this process I showed you is happening hundreds of times in all our body every day, because there are always cells that turn to cancer cells or precancerous lesions, and usually the immune system is eliminating these cells. However, in cancer patients, this has not worked, because now these patients have their cancer and their tumor cells. And there are various reasons how tumor cells could escape these T cell recognition. And therefore, we are inducing these T cell responses far away from the tumor, that is building an immune suppressive environment where the T cells could not detect the peptides. So we provide this vaccination far away from tumor site in an intact immune system and T cell compartment to really induce a strong T cell response that is then able to find the tumor.
So we could see in the next slide, we could already see that you started with injection.
Yes.
So this is the invasive part of your work.
Yes. So I think it's really less invasive. It's like a thrombosis injection. So it's about 500 microliter that we inject subcutaneously into the skin of the abdomen. And this takes place usually 2 to 3 times, depending on the cancer type and depending on the kind of vaccine. And yeah, usually it's very well tolerated. The patient has to stay afterwards 2 hours in the hospital to be sure that there are no acute allergic reactions. Yes, and then the patient can be discharged.
I think you brought a video of a T cell too that has been activated. Maybe we can look at that.
Yes, so it's, I think, much easier to imagine how this process works if you don't not only see my self-painted pictures of the T cell and the tumor cell. Therefore, I brought this electron microscopy picture of a T cell that is killing a leukemic cell. So the small one is the T cell, and you could see when it starts again.
Well, you have to go.
Yeah. So you could see that a T cell is getting connected to the tumor cell by the connection via the T cell receptor and the HLA-presented peptides, and then it lyses the leukemic cell, even if it's much larger than the T cell itself.
Oh, this is very impressive. It's a very aggressive cell. The pure.
Yes, so T cells are really the fighters of the immune system.
Okay.
Any questions left? Or shall we have a look at the production process? What do you think? Production process?
Let's have a look to the production.
Okay, so I think one of the major tasks for the development of new immunotherapies is to close the gap between preclinical development of really novel and promising approaches to the hospital, to really bring this to the patient. And one important part is the production of a medical product that could be given to the patient and gets released from the regulatory authorities. And to get that, we need GMP production, which is good manufacturing practice, of peptide vaccines. And in Tübingen, we have the great possibility to have such a GMP facility that is able to produce personalized peptide vaccines for cancer patients. And what you here could see is the production and analysis process that was shown in the diagram before for the CLL patients. So what we do is we take CLL cells from the peripheral blood of the patients. We lyse these CLL cells to wash down the HLA-presented peptides from these tumor cells so that we really know which peptides are presented on the individual patient's cells. That is what you could see here. And what we then do is to isolate the HLA-presented peptides in a cyclic process overnight. And then these peptides are analyzed in a mass spectrometer to really know what are the peptide sequences, to which protein they belong to, and then to decide which peptides are really CLL associated and are not also found on healthy tissue. And afterwards, we select the best CLL-associated peptides for our individual patient and go into the GMP production. And what you could see here is a so-called peptide synthesizer. It's in a non-GMP area, because before we go to GMP, we have to test all peptides in non-GMP. And you could see here the production of these single peptides that are then composed in a vaccine cocktail. So that's how a peptide look like. And if we have completed all pre-analysis in the non-GMP area, we have to go in the GMP area that you could see here. The same peptide synthesizer, but now in a clean room where you could produce really the drug products for the patients. Afterwards, you have to do a lot of confirmatory analysis. You have to show it's the right peptide that you've produced. You have to do sterility analysis. You have to do stability analysis before you really could then compose the whole vaccine cocktail. That consists on 5 to 10 different peptides. And this is what you could see here. That's in our GMP facility, where the final vaccine product is filled in the final vials that are then shipped to the patient. And this is how the final product look like. So it's a really small vial where the peptide substance is in, and it could then be taken out in the pharmacy, and they prepare the final syringe for our vaccination.
How long? This is most impressive. So how long does it take this whole procedure?
Yeah, so we have two options to produce these personalized vaccine. The first is we produce it really from scratch, personalized. Then it takes us for an individual patient about 3 to 4 months from taking the blood and the leukemic cells. And as this takes a very long time, it's really expensive, we've developed a so-called warehouse concept, where we, based on our preclinical analysis, pre-produce the best CLL-associated peptides, or also peptides for other tumor entities, in a warehouse where we have then about 30 to 40 GMP peptides that we know are CLL associated, and then we could do all this process analyzing the individual CLL cells and then take out the peptides from the warehouse that we think are the best for the patients, and then we have only to formulate it together to the personalized vaccine cocktails.
So how many peptides do you have in host for individually do a composition for?
Yeah, so we have 2 different CLL warehouses right now, including about 30 different peptides where we could take out this. We are currently establishing a warehouse for prostate cancer. We have a warehouse for glioblastoma. And yeah, it would be really a future dream to have warehouses for all tumor entities so that we could offer this personalized vaccine composition to all patients. And with the warehouse, we could do the final filling of a personalized cocktail within 3 to 4 weeks. Wow. Which is still long, but yeah, it takes a lot of regulatory things to do it.
Question, what would happen if you would take all your peptides of your warehouse, 30 to 40, and apply to a patient without knowledge of his antigen profile? What would happen?
I think we would also induce T-cell responses. I think there would not happen more side effects. There will not happen any more allergic reaction. You will still get only T-cell responses to the peptides that are really relevant for the patient. So because we have different HLA typing, so not all peptides fit to all HLA allotype of a specific patient. It would be a nice idea, but the problems are not in the patients, the problems are before, because we only have GMP approval for 10 peptides in one cocktail. So more than 10 is not allowed. And we also won't be able to solubilize 30 peptides in one vaccine cocktail.
But you could apply successively,
yes,
10 for each session.
That would be possible. So we could produce 3 to 4 vaccines and then do 4 injections to the patient. That would be possible in theory.
And what is the rationale for licensing 10 peptides and not 11?
That's a good question. So I think 10 is a nice number, and indeed, more than 10 peptides usually get problems with solubility. So that was just the reason. Of course, it could work in specific cocktails that you could also put in 11 or 12, but when we initially developed this approval process, we decided for 10, and yeah.
Why not switch to RNA vaccination?
Why not switch to RNA? So it's also a possibility to apply vaccines by RNA. However, it's much more complicated to personalize it. So it's much easier to switch peptides, to exclude peptides from a cocktail and replace it by another one. For mRNA, it's much more complicated to produce these completely personalized.
It's most interesting to be part of your discussion. Well, there was a question. Am I right? What is the Perhaps we need the microphone.
Do we have one?
So here's the question. Perhaps you just ask and I translate it.
So from the patients, the CLL patients you see that you treat with these vaccines, what is the relapse rate?
That's a really a good question. We can't answer at the moment because we are still in phase
Could you
1.
just repeat the question?
Oh, yes. So the question was,
Thank you.
how many percent of the patients, of the CLL patients that we treat with our vaccine experience a relapse? And what I told was that so far we really can't tell this because we are still in the phase 1 part of the trial where the primary endpoint is safety and feasibility and immunogenicity. The trial is still running, so we will include 20 patients. We have now included 16. None of them has a relapse so far. However, we need much longer time to really tell you what is really the relapse-free survival. It would be too early to now say none of them has a relapse.
Well, actually, my real question was, and you answered my question, but my final question is, you have a patient who has been treated with this therapy, then, let's say, in a year he relapses. What is the probability that this will undergo the same treatment and will be efficient? With the same vaccine?
Yeah.
Just repeat the question.
You will provide the same vaccine, the same peptide manufacturer, or do you think that the tumor will have evolved in some way, so you need to go through the process, the manufacturing process again for 3 or 4 months?
That's a really good question. So it was asked if there is a relapse after about 1 year in a patient that received a personalized vaccine, that the tumor has changed and we have to really adapt the vaccine. This is also something I can't tell you in detail for CLL, but I can tell you from other experiences that we have from other tumors. We know that the so-called immunopeptidome, which is the entirety of HLA-presented peptides that we see on tumor cell, is very dynamic. And it changes due to cell stress, it changes due to different anti-cancer drugs, and of course the tumor cell will do its very best to downregulate the peptides that are presented and that are targeted by a vaccine. That's the reason why we not only focus on one peptide, because there you will really have a large chance of an immune escape, therefore we take 10. So it will be more difficult for the tumor to escape. We have seen in one patient with a sarcoma that we vaccinated, he was stable for 2 years after the peptide vaccination and then got a relapse, localized in a lymph node cervically. And we took out this lymph node and did again immunopeptidome analysis. And there we really could see that the vaccine peptides were not presented anymore. And we designed for this patient after 2 years completely new cocktail. That is just one case, but it's really important to have a look at these relapses and to analyze to know what the tumor is able to do and how it could escape.
Do you think that same mechanism could apply to virus therapy, or is the virus too quick for the tumor to actually sort of gain mutation?
The viruses are quick, yeah. So it takes about 2 to 3 days to oncolize many tumor cells. The advantage of the oncolytic virus is that whenever you apply it, it sticks to the situation which is present at this time point. So if the tumor is changing over time, month after month, and you come again with the oncolytic virus, always the actual tumor antigens will be presented to the immune system in the course of the tumor cell lysis. So this is dynamic by nature, or by the sketch. Yeah.
There's actually one question from the chat that sort of focuses on the production process or the vaccine itself. The question comes from Patrick James, and he asks what kind of adjuvant you're using for the vaccination.
Also, very good question. I did not mention that so far. We are using for our vaccine trials at the moment toll-like receptor 1-2 agonist that was also developed in Tübingen by Hans-Georg Rammensee, the head of the Department of Immunology. So he worked for many years on novel adjuvants, and we think we really have found now perhaps a new gold standard for adjuvants. So it's called XS15, and we know already that it could induce, in combination with peptide vaccines, really strong immune responses against personalized tumor peptides, but also against viral peptides.
Interestingly, these toll-like receptor agonists, they give the same signal as viruses when they come into. So it's a viral infection which is simulated due to the adjuvant.
Which also makes sense, I guess, in immunotherapy if you have a cold situation and you want to heat it up. Yeah.
So thank you. It is really most interesting. But now we should go back to the patient and the cases. And here we have a movie about the post-interventional situation.
So we made a monitoring, CT imaging monitoring of this tumor during this therapy shortly after the onset of radiation therapy. And as you can see, there's a collage with 4 different time points: February, March, April, and May. And the tumor shrunk considerably at that time, and not only the tumor was no more well vascularized, the attenuation was diminished, as you can see everywhere, and even the mediastinal tumor parts showed a massive reduction in volume and vascularization. The next chest CT showed actually a stabilization of these processes of these residual tumor manifestations along the pleural lining and mediastinum.
Actually, this is going along with the clinical behavior of the patient. Indeed, the patient no longer needs oxygen supply. She is able to move around. Not very speedy, but in normal velocity. And so overall, we are quite satisfied with this result so far. And we would like to depict the course of this multimodal therapy on this graph over there. What you can see over there is that we are using this biotherapeutic approach, off-label use of TVAC, which is a herpes simplex virus-based oncolytic virus, and this has been undertaken now 4 times. This is depicted with the blue arrows. In addition, we applied the immune checkpoint inhibitor pembrolizumab now 3 times, and you see with the black graphs over there, the chemotherapies which have been undertaken in a highly regular manner every 21 days. Initial radiation block, initial HDAC inhibitor, which we not prolonged because of the depletion of the leukocytes and thrombocytes in the course of the chemotherapy, and HDAC inhibitors do exhibit the same side effects on the bone marrow, so we decided to skip that, and we have these regular CT scans helping us to follow the effects of this multimodal therapy.
So if we look at the patient now, can you maybe give us insight into how she's doing right now?
So actually, she is in a quite fair condition. She does not need oxygen, as it was in the beginning. She's able to move. She has quality of life. She is fighting. And we have the impression that we really have been able to bring down this proliferation, not to 0, not yet, but the tumor is growing only relatively slowly. So this is, from our point of view, clinically, for the patient, a great success.
And how did she deal with this whole, I mean, this is been a very fast progress, right? She was, first she didn't know what was going on, then all of a sudden she had a carcinoma, and an aggressive carcinoma as well. And how does she deal with the situation?
So it's lots of talks with her husband, with the family, and I think the most important thing is that she has the thinking that she is at the right address. So not each and every hospital is specializing on such a rare tumor and has this kind of toolbox, which we have here in Tübingen. And I think that's very important for a patient to know, okay, there are specialists, they're trying to do everything, but also having quality of life in mind. So this balancing between most aggressive therapy, but still having time at home with the family and so on. And I think that's important for a patient.
Yeah. To keep up the spirits and help her through that phase.
Exactly. Not only to stay in the hospital, to have treatment after treatment, but to have quality of life and a kind of a perspective.
Let us look to the other case and the post-interventional situation there.
Happily, the patient achieved a partial remission. So we have the sonography data where the lymph nodes decreased a lot, the lymphocyte count decreased, and most importantly, the thrombocyte count went back to normal. So that we then decided to now start a peptide vaccination. The patient received a total of 3 vaccines every 4 weeks. And after the last vaccination, we performed an analysis of T-cell responses targeting specifically the vaccine peptides. And we could show an induction of very strong T-cell responses targeting the CLL cells. So we were very happy about this result. The patients in the meantime showed a further response of CLL disease with further decrease of lymphadenopathy and further decrease of leukocyte count that went back to normal levels. When we have seen the patient at the 6 months follow-up, which was the last appointment of the clinical study.
That was a harsh break. However, I think there was one picture, like in the last few seconds, that you showed that depicted the T-cell response. I don't know whether any of you have experience with reading those kind of T-cell responses. To me, it was novel, and maybe you could...
It looks like the eggs from the small chicken.
I guess it's probably not eggs from a small chicken, but maybe you can explain what it is instead.
No, it's not. So what you could see here is the results of a so-called interferon gamma ELISpot, which is a highly sensitive method to do high throughput screening for T-cell response, functional T-cell response, because T-cells that are activated produce interferon gamma. So we have, on the one hand, the information, are there peptide-specific T-cells and are they functional? Therefore, we use this assay as a standard readout for our vaccination trials. And what you could see here is you have the list of the peptides that were vaccinated in the patient. And here you have the timeline. So this is prior to vaccination, after the first, after the second, and after the third vaccination. And in these wells, which are these small holes, each black dot or dark dot is a T cell that produces interferon gamma up on contact to the specific peptide. And what you just see, if you look here, we have in the beginning no T cell immune response before vaccination. And what you could see here, already after first vaccination, you see these small spots to 2 of the peptides that are further expanded. So after 2 vaccination, we have already spots against 4 peptides. And this is further increasing, and you really could see here a lot of T cells after the 3rd vaccination. Down here you see positive controls, and you could see T cell responses induced by our vaccine are the same amount as we see for the positive control, which is really, really good, remembering that these patients are really immunocompromised.
And how is the patient doing? after that treatment?
She's doing very, very well. We've seen her at the last study visit, which was 6 months after the third vaccination. We still see some CLL cells if we really do these immune phenotyping. So we don't see it under the microscope again, but if we do a detailed so-called minimal residual disease analysis, we still see some CLL cells left. We see T-cell responses even after 6 months, which is really good. And we now do continuous monitoring of the patient. So she sees us every 6 months and her hematologist every 3 months. And yeah, she feels well. Lymphocyte count goes back to normal, thrombocytes, and the hemoglobin level is normal.
She's having a normal life then?
Yes, she's absolutely having her normal life back.
Great. But we have to speak about one topic. I mean, you are an immunologist, and we have a patient with a B-cell deficiency. And right now we are in the pandemic, in the post-pandemic situation, or in the in-between pandemic situation. So how do you deal with patients with a B-cell deficiency?
Yes, so this was a really big problem for us, and I think all hematologists and oncologists in the pandemic, that we have a lot of patients with leukemia and lymphoma that suffer from B-cell deficiency. And as I told before, the B cells are responsible to produce the antibodies. So we have a group of patients that are not able to produce sufficient SARS-CoV-2 antibody response, even up on vaccination. And this was also the case for our CLL patient. When she came to the last visit, she told me she was already 3 times vaccinated with an mRNA vaccine, but did not develop any SARS-CoV-2 antibodies. And she was really afraid because she felt well from her disease, but she was afraid going out, going in the public, going shopping, because she had no antibodies and was really afraid to get severe infection. And therefore, we decided to use our experience in the development of these therapeutic vaccines that are able to induce strong T-cell responses to develop a so-called COVID T-cell activator that provides a broad and strong anti-SARS-CoV-2 T-cell responses to these specific patients that have no antibodies to protect them from severe COVID-19 disease.
So you use T-cells instead of the antibodies from B-cells.
Yes.
That's quite intelligent.
Because we don't have antibodies, so we use the T-cells.
Yeah. We have some slides, I guess.
We don't have slides. We actually have a video left.
A video left.
That maybe we could show now.
3 years ago, Michael Sieber was diagnosed with a form of blood cancer. As part of his cancer therapy, his immune system must be weakened to the point that the currently available corona vaccines are not effective, and that is why he has to limit his day-to-day activities. I try to avoid larger gatherings in enclosed spaces. For example, I couldn't even go to my own daughter's wedding. The risk is just too high. His body doesn't have a proper immune response because of his cancer treatment and can therefore also not build enough antibodies after receiving a vaccine. For patients like this, the University of Tübingen is working on an alternative vaccine. But what's so special about it? The current vaccines use part of a spike protein from the coronavirus as a way to train its defense system. The Tübingen team wants to use more proteins for this so-called training process. We decided to not only focus on the spike protein, but also various other proteins within the virus, with the goal of achieving a wider range immune response than possible with the currently available vaccines. Their vaccine contains 6 proteins from the virus altogether and are used to produce not only antibodies, but also T helper cells to allow the body to fight against the virus. T helper cells can even be produced by those with weakened immune systems. The Tübingen researchers have been developing this vaccine over the past year and are currently running clinical trials on patients with weakened immune systems. Even Michael Sieber is getting his vaccine today. Preliminary results from one study showed that even one dose leads to a strong immunological response in healthy patients. Now it must be tested on patients with weakened immune systems. Over the next few weeks, the participant will be carefully observed, blood samples taken after the vaccination. Michael Sieber hopes that the vaccine can help protect him in the future. I asked the doctors if I'm allowed to go about my day more freely after the vaccine, but they said I just have to be as cautious as before. Because the vaccine must first stand up to trials through results, the study should come to an end at the end of March. This means that those with weakened immune systems must continue to remain in a state of unease, especially with the rising number of corona cases.
So, could you maybe in short explain to us what's the exact difference between the two vaccines that we have, the regular vaccine and your vaccine?
So I think there are two main differences. The first one was already mentioned in the video. So all approved current vaccines are focusing on the spike protein. And therefore, upcoming mutations could lead to an escape of the immune response, which we have already seen for the antibody responses. Therefore, we decided to focus on a broader vaccine product. So we are covering different proteins of the virus. And we are specifically focusing on the induction of T cells. So we do not use antibody epitopes or whole mRNA strains of the spike protein. We use specific T cell epitopes. So these HLA-presented peptides I showed you before for the tumor-associated peptides, the same you have for SARS-CoV-2. And we identified this in preclinical work, in convalescence, and we looked which are the best and most frequent and long-lasting T cell epitopes. And we selected 6 of them and included them in a vaccine. So they are really specifically inducing broad T cell responses.
Wow, it's a novel warehouse part.
Yes, SARS-CoV-2 warehouse now.
Does it work in each and every patient, or do you have non-responding patients?
So we have...
Or vaccinees, so to say.
Yeah. So we have finished the phase 1 first-in-human trial where we vaccinated healthy adults aged 18 to 80 years. There, 100% of participants had an immune response. And we just recently finished the phase 2 trial in the target cohort, which are the immunocompromised patients with B-cell deficiency. And even in this cohort, we could see T-cell responses in 86% of patients. And we are currently completing another phase 2 where we evaluate a second vaccination with the aim to achieve 100% also in this highly immunocompromised cohort.
And how many of these vaccinees get infected?
So we have the data not for all because we only observed them for 6 months. And then we are really dependent on that they phone us and tell us I've got infected. So for the immune compromised, I think where it's most important, we saw in the 56 patients vaccinated so far 5 infections. All were very mild. They don't have to be hospitalized. They got some fever. We had also some patients that had no symptoms at all and were just tested because the rest of the family had an infection. So far, the results are really promising.
The problem with if you don't have antibodies is that if you get in contact with the SARS-CoV-2 virus, that it's inhaled. And normally, IgA antibodies can neutralize the virus. And so that from an infected person, it cannot be transmitted to other patients. This is, I guess, not possible with this kind of approach.
That's absolutely correct. So for the best imaginable immune response, we need both antibodies and T cells. The antibodies are the first line of defense to really protect us from infection. The B-cell depleted patients don't have, so they won't produce any antibodies. We can do whatever we want. So they have only the T cells. Therefore, it's not unexpected to us that they get an infection, that they get PCR positive, because they don't have this first line of defense. So the aim of the study is really to prevent severe causes of disease, to prevent invasive ventilation, intensive care unit for these patients. However, we surely won't prevent infection at all.
Okay, so it is really very, very impressive and interesting. We are very glad to have you here in Tübingen, and also Professor Ramensee, of course. Hello, Professor Ramensee. And it is definitely a pleasure to be in a podium discussion with you, Professor Lauer. Professor Lauer is a most well-known researcher, clinician, and also, and this is something I would like to emphasize, also a teacher. And thank you very, very much for this very interesting 1.5 hours about something which is really was a vision to me, and now it became reality. And obviously, it is reality already. Thanks a lot.
Thank you.
Thank you.